Bienvenido a todos en este segundo bloque del simposio de espectro NMO y enfermedades relacionadas a MOG. Quiero invitar, y para mí es un honor, presentarle al doctor Maciej Jurynczyk, quien es médico consultor en la Universidad de Oxford y actualmente dirige el Centro Biológico y de Resonancia Magnética para el estudio de enfermedades neuroinmunológicas. Hoy nos va a hablar sobre manifestaciones clínicas y factores pronósticos en enfermedad relacionada a MOG. Bienvenido y adelante, Maciej.
Welcome, everyone. Thank you, Dr. Carnero Contenti, for your kind introduction and for your invitation to the symposium. Today I would like to talk about clinical aspects of MOG antibody-associated disease. MOG stands for myelin oligodendrocyte glycoprotein. It is a minor constituent of the myelin with a role that has not been fully elucidated as yet, but it is very relevant from the immunology point of view, probably because it is expressed on the outermost surface of the myelin sheaths. Therefore, it is accessible to antibodies and to other effectors of the immune system. MOG has been repeatedly shown to be encephalitogennic in animal models, and it turns out it is also a target of autoimmunity in humans. It is now widely accepted that MOG antibody disease represents a new CNS inflammatory condition, but this recognition has only been possible thanks to advances in antibody detecting techniques in the last decades. Old assays such as ELISA were using linear denatured MOG epitopes, which resulted in detection of non-disease specific antibodies, which were identified in MS patients and in patients with other neurological conditions, even in healthy controls. Things have changed when constructs containing conformationally intact full-length MOG has been implemented in the assays, and disease-specific antibodies were first identified in children with acute disseminated encephalomyelitis, and then in adults with neuromyelitis optica-like phenotypes. Mogad is currently a hot topic in neurology, and in the last years there has been an increased research activity helping us elucidate various aspects of this new exciting condition. Clinical presentation of MOG is varied, and it is clearly age-dependent. Mogad presents in children often with ADEM, while in adults with optic neuritis or transverse myelitis. Therefore, some researchers think of it as a homogeneous condition that exists on a continuum, but some think of it in a more dichotomous way, because clearly there will be some differences between adults and children in terms of clinical presentation, relapse risk and disability, and therefore also differences in the management. A couple of years ago, we carried out a large UK-wide study where we were looking at the whole spectrum of MOG antibody-associated disease in the UK, including both children and adults, and we were interested in all patients who tested positive for MOG antibodies in the Oxford reference lab. We managed to obtain clinical information on 252 patients, and this was our UK cohort. 75 patients were under our own care in the specialist service in Oxford, led by Professor Pales and by Professor Leiter, and we used this clinical data to study disability outcomes in more detail. And then 44 of these patients were analyzed separately because they were known to our team from the onset of the disease, so they were analyzed as prospective incident cohort ideal to study time to relapse and relapse risk. In the total UK cohort, Females were slightly more affected than males, but this difference was not very marked, and it was also replicated in other studies. The ethnic breakdown was as in the general population of the UK, therefore there was no ethnic bias identified for this condition. Most patients presented with optic neuritis, which was bilateral in about a half. 18% presented with transverse myelitis, and a similar percentage with ADEM or ADEM-like phenotypes, including brainstem encephalitis. 9% had simultaneous optic neuritis and transverse myelitis. In adults, optic neuritis was by far the most common onset presentation, followed by transverse myelitis. Around 1/3 of children presented with ADEM, and children younger than 8 years old presented mainly with ADEM. The age of onset was very broad, and the oldest patient was 81 years old. The mean age at onset was 30 years old. It was interesting to see that the proportion of adults to children in the study was 2.4 to 1, and this is similar to a recently published French nationwide study. Therefore, this might represent a true relative frequency between children and adults with Mogad in the population. It is also worth noting that because other CNS inflammatory conditions are less common in children than in adults, in particular MS, Mogad represents around 30% of acquired demyelination in children, so this is a substantial portion of all children in pediatric neuroimmunology clinics. This graph shows an estimate of relapse risk in the Oxford incident cohort, where a median disease duration was 16 months. And at last follow-up, 36% of patients relapsed. We wanted to look whether this relapse risk will differ depending on different onset phenotypes, and we found out that patients who present with optic neuritis with or without transverse myelitis are more likely to relapse than patients who present with ADEM or transverse myelitis. Another interesting observation was that the second attack of Mogad is usually optic neuritis. There are three main factors that have been identified to affect relapse risk in Mogad for the moment. The first one is definitely age, with children being less likely to relapse than adults. In two recently published prospective incident cohorts, around 80% of children with first Mogad attack remained monophasic after a median observation of 4 to 6 years. The second factor is treatment, and I will not talk about it in detail as this is a topic of another lecture. However, early prolonged immunosuppression will mitigate the risk of relapse in this condition. And the third factor is antibody status. In our study, we obtained information on 57 Mogad patients who had at least 2 tests performed at least 6 months apart, and the median disease duration for this subgroup was 37 months. And 25% of patients turned and stayed negative over time. Most of this negativity occurred within the first year from disease onset, and in this subset of patients, we have not observed any relapses. The effect of antibody status on the relapse risk was also recently observed in the French study, but more so in the pediatric cohort than in adults. At 2 years, 60% of non-relapsing children became MOG antibody negative as compared to 15% of relapsing children. Optic neuritis is the most common presentation in Mogad. It is simultaneous bilaterally in about up to half of all the patients. And in the acute phase, optic neuritis is usually quite severe. Visual acuity at nadir of the worst attack is quite poor at the level of count fingers. Usually it's the first attack that is the most severe, and this visual acuity in the second optic neuritis is usually at a level of 0.2, so better than the first attack. Acute optic neuritis is very frequently associated with pain and with optic disc edema. In about half of patients, optic disc swelling is moderate to severe and might involve peripapillary hemorrhages. There are also some characteristic imaging features of MOG antibody-associated optic neuritis. In particular, there is an enhancement of the optic nerve that is quite extensive. It affects not only the optic nerve, but also perineural tissue. If optic neuritis relapses, we might encounter different phenotypes. The most common one is recurrent optic neuritis, and sometimes we can even talk about chronic relapsing inflammatory optic neuritis, CRION, if the condition is very steroid dependent and steroid responsive. If patients relapse with transverse myelitis or with ADEM, we will see NMISD phenotypes or ADEM type phenotypes. Despite marked severity of optic neuritis in the acute phase, the outcome is usually quite favorable. We were studying this in our Oxford cohort, where median disease duration was 28 months, and we observed that the majority of patients had significant recovery from optic neuritis. Only around 16% had visual acuity 6/36 or less in at least one eye, and most of these patients had disability coming from their onset attack, and all these patients had optic neuritis at onset. Bilateral profound decrease in visual acuity was rare and affected only around 3% of patients, and this is much less in comparison to what we observe in aquaporin for antibody disease after the same median disease duration, where this risk is around 7-fold higher. Transverse myelitis is a presenting feature in around 30% of Mogad patients. It can occur in isolation or is associated with optic neuritis or with ADEM. It might be preceded with prodromal symptoms in about half of patients. These might include malaise or low-grade fever. Obviously, it presents clinically as acute flaccid myelitis with weakness, neurogenic bladder, and around 1/3 of patients will be wheelchair dependent at nadir of the attack, which is quite similar to what we observed in aquaporin for antibody disease in the acute phase of the transverse myelitis. On imaging, we usually see longitudinally extensive transverse myelitis. Sometimes it can extend to dorsal medulla, which is very similar to what we see in aquaporin for antibody disease. Around 40% of patients have conus involvement, which is considered to be quite a typical feature of MOG antibody-associated disease, but as you can see, it does not occur in all patients with MOG antibody-associated transverse myelitis. If there are relapses following transverse myelitis, and as you might remember, transverse myelitis might have a slightly less tendency to relapse than optic neuritis, but if it relapses, it might relapse with optic neuritis leading to NMISD phenotype, or we might have a patient with recurrent transverse myelitis. It might be also followed by ADEM, giving ADEM type or Mogad type of phenotypes. Again, although the acute transverse myelitis is quite severe at nadir of the attack, the outcome is usually quite favorable, at least in terms of motor disability, because only 5% of patients will have disease at least 6 or more at last follow-up, so therefore they will not be able to walk 100 meters or more without aid. This disability comes always from transverse myelitis and can come from the onset attack, but also from subsequent attacks. Again, this disability is much less as compared to aquaporin for antibody disease, where this poor outcome is seen around 5 times more often. Kind of out of proportion to motor disability, we encounter permanent bladder dysfunction in up to 30% of patients. And in 2/3 of patients, this is quite profound bladder dysfunction requiring long-term catheterization. Bowel and erectile dysfunction occur only in patients who also have bladder dysfunction. And in particular, as many as 44% of male with transverse myelitis at onset will have erectile dysfunction. Romina Mariano from Oxford, she was looking in more detail at the comparison of transverse myelitis between MOG antibody associated and aquaporin 4 antibody associated disease, and she found that persistent bladder dysfunction is more common in MOG antibody disease than in aquaporin 4 antibody disease. However, the poor outcome of catheterization was similar between the two groups. Apart from the most typical Mogad presentations such as optic neuritis, transverse myelitis, and ADEM, we also may encounter some more unusual presentation, and the most striking one is unilateral cortical encephalitis, which was first described by a Japanese group. This encephalitis presents with seizures, abnormal behavior, and altered consciousness. What is quite typical is first that it's steroid responsive and has a good prognosis, and the second is imaging, which shows swollen cortex on one side of the brain. And this swelling is not necessarily a consequence of seizures, because it was also seen in patients who didn't have seizures or in patients that had an MRI before seizures. The second interesting form is brainstem encephalitis, which can be interpreted as a form freest of ADEM or limited form of ADEM. It has a quite striking imaging appearance associated with the presence of fluffy infratentorial lesions, which are often located in middle cerebral peduncles. Brainstem encephalitis may accompany optic neuritis or transverse myelitis, but can also be isolated. Finally, ADEM is the most typical presentation of Mogad in children. In general, around 50% of pediatric ADEM is associated with MOG antibodies, and it is difficult to predict whether ADEM is associated with MOG antibody or not, just on the basis of clinical presentation or imaging, but there might be a tendency for more widespread large lesions in those who have MOG antibody. Clinically, ADEM will present with encephalopathy, multifocal deficits, and around 20% of patients might have seizures. MOG antibody is definitely a risk factor for a relapse in ADEM, and ADEM has a tendency to relapse in children, in particular if antibody persists on subsequent tests, and we might encounter various phenotypes such as multiphasic ADEM, and many neuropediatricians believe that around 100% of multiphasic ADEM is linked with MOG antibody. Other phenotypes will be ADEM followed by optic neuritis or ADEM followed by NMOSD. Prognosis in children is usually favorable, and most children recover promptly and nearly completely from the onset attack. Some might have poor concentration or some learning difficulties, but the poor recovery is seen in around 20% of children, and this is linked with two main situations. The first one is recurrent ADEM, leading to a striking leukodystrophy-like pattern on imaging, and the second situation is encephalitis that predominantly affects the cortex and leads to cortical atrophy. So children with poor outcome might have progressive cognitive decline, visual loss, cerebellar ataxia. In around 20%, we might encounter post-ADEM epilepsy. Obviously, CSF is very helpful in the differential diagnosis of CNS conditions. So I should mention that in Mogad, CSF is usually unremarkable or normal. Patients might have elevated protein or elevated cells, usually moderately. An interesting observation is that around 15% of Mogad patients might have white cells above 50 per microliter, and this could be some sort of a discriminator, in particular with MS. And only 10% have unmatched oligoclonal bands. So obviously the differential diagnosis of MOG antibody-associated disease includes aquaporin 4 antibody, NMOSD, and MS. So it is good to know differences and similarities between these conditions. In terms of demographics, Mogad is characterized by only slight female predominance, and there is no ethnic bias identified for the moment. A substantial portion of patients are children, around 1/3 of all patients. Clinical features that will be typical for Mogad include bilaterality of optic neuritis and the presence of optic nerve disc swelling on fundoscopy. Also, predilection of transverse myelitis for the conus, which leads to frequent bladder disturbances. Also, Mogad is characterized by ADEM in children, a phenotype that we do not see as often in two other conditions. It has less tendency to relapse, and this is in particular seen in children. It is also worth noting that the spectrum of Mogad is wider than that of NMOSD, and only 25% of Mogad patients will fulfill the current NMOSD criteria for aquaporin 4 antibody negative disease. The reason for that is that this criteria require the presence of disease in at least two sites, so for example optic nerve and spinal cord. Patients with a single site disease or patients with very extensive disease such as ADEM will fall outside of this criteria. And also a recent Argentinian study reports a similar percentage of Mogad patients fulfilling aquaporin 4 IgG negative NMOSD criteria. In conclusion, MOG antibody disease is a new and separate disease, and we should think about it differently than we think about aquaporin 4 antibody disease and MS. It can present at any age and most often with optic neuritis, but the exclusion are children younger than 8 years old, where ADEM is the most common onset presentation. There does not appear to be any sex or ethnic bias. Relapses in this condition are quite common, more so in adults than children. They often occur quite early, within the first 6 months from the onset attack. Optic neuritis might be more likely to relapse and is the most common type of relapse. Prognosis is in general more favorable than in aquaporin 4 antibody disease, in particular as far as visual function is concerned and mobility is concerned. However, permanent sphincter and erectile dysfunction is quite common. It is also interesting to see that majority of disability comes from the onset attack, and this is in particular for patients with optic neuritis. So thank you very much for your attention. I regret I may not be available for the discussion, but I wish you all the best in these challenging times, and I hope that we might meet soon face to face. Thank you very much.